So thank you all for coming out. It's a bit, it's a bit wet, it's a bit mopey, it's a bit cold, but thanks everyone for still for tuning out. I am Dr. Gregory Boyce of Mrftt, and this is our Mrftt Hiv Sti Echo. Dr. Edwards is on leave, but in his absence, especially given his excellent previous presentation on this topic and the recent announcement by WHO that Mpox is back, and this is again going to give us a bit of trouble. We're not sure how much just yet, and we seem to have dodged the bullet last time. We only got 2 cases, 2 or 4 cases, sorry. Dr. Edwards was the person who identified all the cases, was instrumental in actually working with those persons, ensuring that they were quarantined, and he essentially stopped the outbreak single-handed. I mean, if you can say so. And so we're very grateful for his expertise and his leadership there. So we thought we would revisit the topic because it may have fallen out of memory just a little bit, and some of the cases that present can be done in very subtle ways. If not for Dr. Edwards' own expertise, both in venerology and dermatology, the cases might have been missed. So I think we'll take the opportunity to again learn from Dr. Edwards about Mpox. Not much of the medicine has changed. He gave a very comprehensive presentation last time. And at the end, I'll give just a brief synopsis of some of the recent data with respect to where some of the new cases are coming and some of the recent epidemiology surrounding Mpox. So I will just turn over to Conrad to start the presentation. Thanks a lot, Conrad.
Please let me know if you can see the screen. Are you seeing the share, Greg?
Yes, sir.
Awesome. Thank you so much. You can begin.
Good afternoon, everyone. Getting ready to start. Just remember, if this is your first time with us, welcome. We're very much happy to have you. Remember to indicate your name and where you work and what category you're staff, whether you're a nurse, social worker, psychologist, anything, in the chat box so we can make a note of who all our guests are today. So again, thanks and welcome to everyone. This is a special HIV STI echo that's not dealing with HIV or STIs this time, but is dealing with something that's very topical. We just came out of one viral pandemic, and lo and behold, we get this new one, which we hope to not reach pandemic status before. No down or alley. And so as I put up in the WhatsApp group, case has been confirmed in Brazil. It's kind of following up this South American, was in Argentina, now it's in Brazil. And we know these things. I remember there was a Far Side comic, for those of you who remember that comic. Be a virus, see the movie. Viruses go everywhere, no matter how well we are, how hard we try to contain them. So this new monkeypox virus, even though it's not really new, but new as in terms of outside of these endemic areas like usually how it is. What do you need to know? How do we prepare? What do we need to look for when these cases eventually come to us? And we're quite happy to have Dr. Mrftt Edwards, just to my left, who's going to give a presentation on this specific thing. So please feel free to ask questions. There's no such thing as a bad question or a silly question. And with that said, Dr. Edwards, over to you.
Okay, good afternoon, everybody. Thank you for joining this Zoom session on monkeypox. It will be short, probably about 30 minutes. I actually gave this talk to the Medical Association last week. And a lot of the slides I got it from my CDC colleagues, so it's up to date. But last week I tried to update it again. All right. So let's get going. So in terms of the presentation, I'll do an introduction, the epidemiology, the motive, clinical features, diagnosis, prevention, what clinicians need to know about monkeypox. Somebody noted. Okay, so let's talk about monkeypox. Monkeypox is a viral zoonotic disease that occurs primarily in the tropical rainforests of Central and West Africa, and is occasionally exported to other regions, but we see more and more other non-endemic regions are getting it. The clinical presentation of monkeypox resembles that of smallpox, which is a related orthopox virus, but is very much more mild than smallpox. So mass vaccination occurred against smallpox, and then there was targeted vaccination and surveillance against smallpox. This resulted in the elimination of smallpox in 1997. And then WHO looked at it and they declared that smallpox was eradicated in 1980. So as a result of this, there's a subsequent cessation of smallpox vaccination. So people who are older than 40, 45, you know, who are younger than 40 or 45 probably wouldn't have gotten smallpox vaccination. Go ahead, next one. So monkeypox has emerged as the most important orthopox virus, which is an envelope double-stranded DNA virus. Due to the absence of vaccine-derived immunity, they found that vaccination against smallpox somehow protected persons against developing monkeypox. Again, monkeypox is less contagious than smallpox and causes less severe illness. The natural reservoir of monkeypox is unknown. However, the animal hosts include a range of rodents and non-human primates, for example, monkeys, including rope squirrel, that's the rat you see in there on the screen, and the dormies. Next one. So monkeypox belongs to the orthopox virus genus, all right, and this also includes variola virus, which is a smallpox virus, the vaccinia virus, which is a smallpox vaccine, or cowpox. Monkeypox was first isolated in 1958, when it was discovered that there was a pox-like disease in monkeys kept for research in Copenhagen, Denmark. So hence the term monkeypox, because it first presented in monkeys. In 1970, human monkeypox is identified in a 9-year-old boy in the Democratic Republic of the Congo. There are two clades or two strains of the monkeypox virus, the West African strain, which is a less severe disease, and then the Congo Basin strain, which causes more severe disease. So they have differences in pathogenicity. So since 1970, human cases of monkeypox have been reported in 11 African countries. And you can see them there. Nigeria is important. So looking at Nigeria, confirmed cases occurred in 1971, 2, and 1978. And between September 2017 and December 2018, there were 311 reports from 26 states in Nigeria. There were 132 confirmed cases from 17 states and 7 deaths. And the mean age of onset of the disease was 29 years old. And the largest outbreak of the monkeypox was a West African strain, number that's a less severe strain, and with continued consistent reporting and confirmation of cases. Next one. So monkeypox has now migrated to non-endemic countries. In the US, in 2003, there was an outbreak linked to shipment of wild animals for distribution in the pet trade. There were 47 confirmed and probable cases. However, in this outbreak in the US, there was no human-to-human transmission. There were also 9 travel-associated cases from Nigeria between 2018 and May 2022. Of course, there's much more now. 5 cases in the UK, 2018, you can see 2, 2019, 2020, and 2021. 1 case of travel-associated monkeypox in Israel, 1 Singapore, and 2 in the US in 2021. However, even though these cases came from Nigeria on flights, there were no flight contacts. So people sitting down next to these persons with monkeypox in a plane, they didn't develop infection, indicating that monkeypox is not easily transmissible. All right. However, in the UK, one healthcare worker developed monkeypox from one of these patients, and 2 family members acquired monkeypox from these patients. Go ahead. Next one. So how is monkeypox transmitted? Transmission occurs when a person comes in contact with a virus from an animal, human, or materials contaminated with the virus. So the virus enters the body through both the skin, the respiratory tract, or the mucous membranes. Animal to human or zoonotic transmission may occur by a bite or scratch from an animal. If some people, if they prepare just wild meat or bush meat, if they come into direct contact with blood or body fluids or lesion material, or indirect contact with lesion material, such as through contaminated bedding. So somebody monkeypox on a bed, the bedding becomes contaminated, and you come in contact with that. Next one. In terms of human to human transmission, this may occur either directly or indirectly with contact with body fluids or lesion materials. Contact with fomites, for example, the bedding, or exposure to respiratory secretion. So some examples of high and intermediate risk exposures include shared towels and bedding. So the infectious body fluids and the scabs may be present on these. Skin-to-skin contact with a person who has monkeypox. Or if you're inside a room or within 6 feet of a person with monkeypox and they're doing procedures that may create aerosols, all right? So if you're doing a procedure, a healthcare worker, and you should wear N95 mask, okay, or higher, and you should probably wear eye protection. The good news is that monkeypox is not easily transmitted. So the folks from CDC have actually said they don't expect monkeypox to be the next pandemic because it's not easily transmitted. And it's been around since 1958 and 1970, the first case in humans. Next one. So in terms of the clinical features, incubation period is between 6 and 13 days. It ranges from 5 to 21 days. And the infection can be divided into 2 periods. The invasion period, which lasts between 0 to 5 days, is characterized by fever, headache, swollen lymph nodes or lymphadenopathy. So swollen lymph nodes is a distinctive feature of monkeypox and distinguishes it from chickenpox, varicella, or smallpox. In addition, they may get backache, myalgia, which is muscle pain, and fatigue or tiredness. Next one. And here you can see the lymph nodes in the neck of a patient with monkeypox. Large nodes may also be seen in the mandibular, on the jaw, cervical, the neck, inguinal, in the groin, okay, in patients with monkeypox. Next one. And then after the initial phase, a rash develops, and the rash develops within 1 to 3 days of the appearance of the fever. Now, what I'm going to describe here is the classical monkeypox that is present in Africa. Later on, I'll tell you how monkeypox has atypical features. So the classical rash in monkeypox, right, tends to be concentrated on the face and extremities rather than the trunk. It affects the face in 95% of cases, palms and soles in 75% of cases. And remember, if you see a condition affecting palms and soles, what do you all think? Syphilis. Secondary syphilis, all right? So that's why they asked me to talk about it, because the monkeypox affects the palms and soles, and STI is a big differential diagnosis. It may affect the oral mucous membrane in 70% of cases, the genitalia, as you can see, in 30% of cases, the conjunctiva, that's the eye, as well as the cornea, in 20%. Next one. So what does the rash look like? It starts off as a macule, which is flat, then becomes a papule, which is slightly raised, then becomes a vesicle, which is a fluid-filled raised lesion, a pustule, a raised lesion with pus in it, and then this crosses over, and then desquamates, all right? So you tend to see these deep-seated, firm, well-circumscribed lesions with central umbilication, meaning there's a little umbilication in the middle, all right? and they may actually become confluent, join with one another. The lesions tend to be of similar size and at the same stage, unlike chickenpox, where they tend to be of different stages, you know. So most of the lesions in monkeypox look the same, you know, and the rash is often present on the palms and soles. Pain and itching, pruritus and itching, may or may not be present. So the patient's infectious once the symptoms begin, so from the fever or the rash until the lesion scab and the scab falls off. And the number of lesions on the body varies from a few to several thousand. And just to show you here, you can see here, you can see some slightly raised lesions. So there are some papules and vesicles being fluid filled. B and C, you can see these flat lesions, they're vacuoles, round lesions on the palms and soles. D, you can see a pustule with a red ring about it, so erythema, and a pustule and a halo, red ring around it. And then E, you can see it affecting under the nails, so this is called a subangular lesion. F, you can see the small papule, a papular raised lesion. G, you can see it started to become fluid filled a bit, so it's not visible. And then H is actually a deep abscess that was found at ultrasound. So they're going to drain it at ultrasound. Next one. Again, you can see vesicopustules with a red halo, a red ring around it. And you can see a little dot or umbilication in the center there. All right. And the other one is the umbilicated papule on the lower part of the leg. So these are what monkeypox tend to look like. Next one. Again, you can see the different lesions. And if you notice the ones in the palms and in the forearms, most of them tend to be about what's the same size and shape, all right? But they're at similar stages. And remember, unlike chickenpox usually affect the palms, also may have one or two lesions, but monkeypox affects the palms and soles. Next one. And this one just shows some satellite lesions. So you can see a couple lesions where the blue arrows radiated from the main lesion. All right. But monkeypox, the good thing is usually a self-limited disease. So most patients, the vast majority, symptoms resolve in 2 to 4 weeks. So not really a serious illness. However, some severe cases can occur, especially among children. All right. And this depends on the extent of virus exposure, the patient health status, and the nature of complications. Of course, if you have an underlying immune deficiency, you may have a worse outcome. And immune deficiency could be things like cancer, and, you know, HIV infection, if you have a medication. Vaccination against smallpox offers some protection. So patients who are younger than 40 to 50 years of age, right, may be more susceptible to monkeypox because your persons haven't been vaccinated. Because smallpox was eradicated in 1980 and they stopped vaccination. I got it, so I'm older than that. So some of you all, and you can tell it, you see the scar on the arm, that's how you can tell that's smallpox. Next one. Now there's some additional complications. As I say, these complications are rare. You may get a pneumonia, you may get dehydration, might affect the GI tract. You could get secondary infection, it could affect the eyes, you know, it could affect the brain and cause encephalitis. It can affect the skin and they cause scarring, so you get these pock marks, you know, and very rarely deaths, you know. The extent of asymptomatic infection is unknown, and the fatality rate ranges from between 1% to 10%. 1% for the West African clade and 10% for the Congo Basin clade. All right, next one. In terms of diagnosis, so persons who collect samples from patients with monkeypox should use the appropriate PPE, all right? So ideally, you should sample more than one type of lesion, preferably from various parts of the body. So what you can do is vigorously swab or brush the lesion, all right, with 2 separate dry polyester or decon swabs, all right? One for preliminary analysis and one for confirmatory testing. In the US, they can identify the preliminary analysis that is an autopox virus. But for confirmatory testing, you have to send the sample to CDC and they will tell if it's monkeypox or not. So most of the states can do autopox virus. We said, so they know that, but autopox also could be smallpox, you know, it could be varicella, you know, it could be cowpox, not varicella, variola vaccine, or it could be cowpox. So after you collect the swab, you break off the end of the applicator, all right, into a 1.5 or 2 mils screw cap tube with an O-ring, all right, or you can place the entire swab in the container. And they suggest that you shouldn't add any viral transport media, you should ship it dry. As I say, monkeypox is usually diagnosed by PCR, usually at the CDC. A lot of the labs in the Europe can also diagnose it also. Next one. In terms of treatment, so many individuals infected with monkeypox have this mild self-limited disease. So most people don't need any treatment. Most people get it and in 2 to 4 weeks, they're better. However, the prognosis for monkeypox depends on multiple factors, such as previous vaccination status. So if you had smallpox vaccination in the past, it tends to give you some protection against monkeypox, the initial health status, and if you have any concurrent illnesses or comorbidities. So the clinical care of patients with monkeypox should be fully optimized to alleviate symptoms, manage complications, and prevent long-term sequelae. And if there's secondary bacterial infection, you can treat it antibiotics as needed. In terms of treatment guidance for monkeypox, all right? As I said, most people, mild disease, they get that in 2 to 4 weeks. However, patients with severe disease, for example, if there's hemorrhagic disease bleeding, or if the lesions join together, becoming confluent, or if there's some kind of infection, they may require hospitalization. So people who may be at high risk for severe disease are those who are immunocompromised for whatever reason, cancer, against steroid therapy, you know. Pediatric population, so children, usually younger than 8 years of age, pregnant or breastfeeding women, or persons with one of the complications that I described earlier. So these are the persons who are at risk for severe illness. But just to say that most people get better, all right, in 2 to 4 weeks. Most people recover, no problems. Next one. So in terms of treatments, now the US have actually stockpiled treatment for the autopox viruses. So they have a drug, an antiviral drug called tecovirimat, which has been licensed by both the European Medicines Association and the FDA, all right, for treating monkeypox. Oh, sorry, it was developed for smallpox and licensed for treating monkeypox in adults and pediatric patients. So tecovirimat, again, CDC has that available. Cidofovir, which is a antiviral, again, it holds this expanded access, you know, new drug treatment for autopox viruses, including monkeypox and outbreak. We've used cidofovir in the past, and then there's a vaccinia immune globulin, which is licensed for the by the FDA for the treatment of complications due to vaccinia vaccination. So if you get a smallpox vaccination and you have complications, you can use the vaccinia immune globulin. And this also holds this expanded access investigation, new drug approval for treatment of autopox viruses, including monkeypox in an outbreak. So these treatments are for high-risk species, all right? Not available, the CDC has access to this. They stockpile these drugs. Next one. In terms of prevention of monkeypox, all right? So quick identification of exposures, contact tracing, you isolate the persons, all right? And you isolate them usually for 21 days, right? To limit further spread. So we did this with COVID, and the persons who have diagnosed with COVID, we tell them stay at home, isolate until they become negative. Usually with monkeypox, we isolate them for 21 days. We carry out community education. We try to avoid contact with animals or fomites that might harbor the virus. You need to train you have healthcare workers and train people and reinforce good practices in healthcare facilities. For example, remember hand hygiene and wearing the PPE, wearing the masks and stuff. And as I mentioned before, previous vaccination against smallpox was demonstrated through several observational studies to be cross-protective. As a matter of fact, some of the studies went as far as to say it was 85% protective against people developing monkeypox. However, remember we got these vaccines years and years ago, so the immunity may wane with time, all right? Also, if you've been vaccinated with smallpox, you may get a milder illness if you do get monkeypox. So smallpox vaccination tends to help, all right? Next one. Again, the US has stockpiled 2 vaccines, okay, for the prevention of orthopox viruses. There's one called Jynneos, which is an attenuated live virus vaccine. And this has been approved by the US FDA for the prevention of monkeypox in high-risk contact. So if you come in contact with somebody with monkeypox and in the US, the CDC can give you this vaccine, Jynneos. And there's another vaccine called ACAM 2000. This is a newer smallpox vaccine and replaced the older one. Remember the one that they stopped years ago? And the US stockpiles this in case there's some biological warfare. So they have this live replicated vaccine available for immunization of persons who may be at risk for developing smallpox. So if you're working with smallpox or you're thinking that, you know, there might be some biological warfare, the US has these vaccines stockpiled. Next one. So in terms of a situational analysis here, this was as of May 22nd, 2022. You can see 251 cases. But go to the next slide.
Hey, Dr. Edwards.
I actually looked at it, looked at the WHO site and the update. Okay. So in non-endemic areas, so that means regions outside of Africa, they reported to the WHO as of June 8, 2022. So there are a total of 704 cases, all right, in the 18 European Union countries. Most cases were young men who have sex with men, with no deaths. And the clinical presentation is totally different in non-endemic countries. Most of the cases tend to present with lesions on the genital area or around the genital area. However, transmission is not thought to be due to sexual contact. Transmission is thought to occur probably due to close physical contact during sexual activities. Outside of Europe, there have been 473 cases confirmed in non-endemic regions outside of Europe, in the Americas, Australia, and Asia. So a total of 1,100 cases in non-endemic areas. Those are areas outside of Africa, wherever. So what makes this 2022 outbreak so different? So what is different about it? There are a large number of cases in multiple countries outside of Africa. And some of the cases occurred in men who have sex with men. As I mentioned, it's not thought to be sexually transmitted. It's thought to be transmitted by close body contact. Apparently, there are two rapes, one in Spain, I think one in Belgium, and people who came back from those rapes, whatever rapes are. You all people know it. You all younger people know the rape, right? It's a big party. All right, great, yes. So there are two big rapes, one in Spain and one in Belgium. People came back with it. All right, they came back with somebody MSN who came back from those things, came back with monkeypox. Now, what's also strange now, there have been important cases in persons who have no travel history to countries where the virus is endemic. And in terms of how the rash and how it clinically presents, the rash still has the same appearance, but it now starts in the genitals and around the anal areas. Another proctitis, which is inflammation, you know, of the rectum. And sometimes it might not spread to other parts of the body. So as a result of it presented in the genital and around the anus, cases are now recognized in outpatient or STI clinics because you easily confuse them with STIs. They may have the fever and stuff, they may or may not have them. We don't know the reason for the unusual presentation at this time. So outside of Africa, a lot of it tend to present in the genital area and looking like an STI basically. Next one. So what they did was, so remember when we had COVID-19 and you had all these different variants, you had the Omicron variant, you had the Delta variant. How we knew what variant we had in Trinidad was they would sequence the virus, all right? And then they could say, okay, we have Delta now in Trinidad. So what they did was they had 13 viruses, 9 from Portugal, 2 from Belgium, 1 from Germany, and 1 from US. They sequenced it and they found that all the virus was consistent with the West African clade, Senior Nigeria. Remember, the West African clade is a less severe disease. And they found that even though the virus is present in different countries, it doesn't seem to have mutated to a more easily transmissible form. So it's not as easily transmissible as COVID, all right? So West African clade, less severe, and it hasn't mutated to a more transmissible form. So which is good news for us. So CDC do not think it'll become a pandemic unless something happens here. Next one. So what clinicians and healthcare workers need to know? CDC issued a health advisory on May 20th, 2022, advice for clinicians. So be vigilant to the possibility of monkeypox if a characteristic rash is present. Note that the rash is presented atypically different. It presents in the genital area, all right? So clinicians working at STI or patient clinics may be the first to suspect monkeypox. Many patients have minor symptoms and it's easy to confuse with a sexually transmitted disease or with varicella. As a matter of fact, after I gave this talk last week, when the doctors called me, "Doc, this patient walked in the office, there's monkeypox." As they sent me some photos, the patient had chickenpox. So again, it's difficult to distinguish sometimes, all right? Varicella zoster, which is shingles, or varicella, which is chickenpox, from monkeypox. But if you have a patient and you suspect, obtain a sexual history, obtain a travel history to determine if they had any contact. So that patient was a young boy, he was 12 years old, and 2 other people in the class had similar rash. So I say, well, you know, there's chickenpox, you know, okay? Obtain specimens, notify the Ministry of Health, and consider initiating contact tracing to isolate the patient to stay away and do contact tracing, and of course, facilitate laboratory testing. So what clinicians need to know in terms of treatment and prevention? All specimens reported outside of endemic areas to the WHO have been found to be the West African clade, all right? This is associated with milder illnesses. And because the illness is mild, supportive care is enough, so they drink fluids, isolate at home, take Panadol, they have fever, and you know, it should be fine. If there's severe disease, then the Ministry of Health will have to contact the CDC to get those antivirals that I mentioned, all right? In terms of contacts, you should monitor healthcare patients, personnel should monitor the contacts and monitor them for 21 days. There's something called post-exposure prophylaxis. So if after you've been exposed to monkeypox, the US has those 2 licensed vaccines that I mentioned before, then available from the CDC. And if there's something called pre-exposure prophylaxis. So people who was with smallpox and stuff normally get vaccinated against smallpox using that new vaccine that I mentioned. And then called pre-exposure prophylaxis for certain healthcare personnel. All right. So those are my references. If there are any questions, I told you it'll be 30 minutes. So any questions anybody want to ask, feel free.
Thanks, Conrad.
Back to you.
Thank you, Conrad. Thanks, everyone. So I would have truncated the presentation at that point. But if anyone has any questions, what I suggest to you, given that I'm not an expert in this area, I will always email the questions just put them in the chat and we can get the answers back to you. What I will do now is just a brief presentation of updates since 2022 in terms of the epidemiology, because a lot of the medicine hasn't changed, the clinical presentation hasn't really changed very much. But there are some new little wrinkles that have come to our attention as a medical community since that initial outbreak 2 years ago. So let me try to get this going. Excuse me, sorry. All right. I'm hoping everyone's seeing the screen here. Is that right?
Yes, we can. Thanks, Greg.
So, all right. Oh, sorry. Technologies again being a bit unhelpful. All right. So just a brief update in terms of what's been happening with what was called monkeypox. As you realize, we during the presentation 2 years ago, we used the word monkeypox very often. Shortly after a presentation, the WHO would have recommended we use the phrase Mpox instead of monkeypox, right? So we will refer to the disease as Mpox throughout this presentation. Just acknowledgements of the support of ITEC and the University of Mexico for the ECHO program. I have no disclosure with respect to Mpox. And we just want to discuss briefly recent changes in the Mpox, I guess we can call it pandemic, and the implications for the Caribbean region. So on May 11th of last year, the WHO would have made an announcement that Mpox was no longer considered a public health emergency of international concern. Why? There was a over 90% decline in cases over the preceding 3 months. But they did emphasize that countries should maintain surveillance and response capacity, and they should continue to integrate Mpox prevention and care into routine national health programs to address future outbreaks, because we know with viruses, they flux and wane, and there's always a possibility, as has been in this case, that there may be a recrudescence of the virus. One of the issues that was highlighted in that presentation was a concern by WHO about the consistency and durability of preventive response. And if we were not careful, if we took eye off the ball, that we could get another worldwide spread, all right? So fast forward just over a year later. So just about a little over a week ago, the WHO again declared that due to the rise in Mpox cases, that it is now a public health emergency with national concern. There were increasing cases in Democratic Republic of Congo and with expansion to some of the neighboring countries. The spread in DR Congo we thought was due to clade 1A, that is the Congo Basin clade, and there was a new Mpox virus clade discovered, clade 1B. There was some concern that this particular clade was more easily spread among young people, and there was also some preliminary concern that they may be it may be responsible potentially for more severe disease. So I think as more data comes in, we'll be able to make more definitive statements about severity and transmission. So far for the year, there's been just over 3,500 cases, including 26 deaths, as Dr. Edwards' presentation did say. Thankfully, Mpox is not generally a fatal disease, somewhere between 1 and 10% of cases, and that's that mortality rate dependent on things like immune suppression, comorbidities, how well the patient is, and so forth. And in terms of the caseload, DR Congo is far and above the leader in new cases with 3,235. Burundi, is less than 1/10, less than 5% of that with 153. And the Central African Republic is just 45 cases. So right, predominantly in DR Congo, but we know from previous experience, if this outbreak is not, managed appropriately, we will see spread outside of Africa. And this is just a graphical representation since 2002 to now, and you see that those blue spikes going up, that in DR Congo there is, especially in the last 6 months or so, a spike in cases, and with some increased cases in Burundi, Cote d'Ivoire, and so on. But I wanted to highlight this particular data point because I think it illustrates, very nicely that we need to not think of Mpox as an African problem. So in terms of the global distribution of disease since 2022,
in the USA, the numbers were 33,500. I remember that old saying, when the United States sneezes, the rest of the world gets a cold. So we need to be mindful of the fact that this could be a global problem and a regional problem, right? So United States 33,000 plus, Brazil, our close neighbor, 11,800 plus, Spain 8,000, DR Congo comes in fourth, right? France, Colombia, Mexico, right, and United Kingdom. And in terms of the case profiles, for where there is existing data, so men have sex with men, right? From February to now, 95.8% cases where data is available are among men who have sex with men. Persons live with HIV, about 43%. There's some health worker involvement, of course, persons who are taking care of clients and who are affected by Mpox may themselves be affected. There were many presentations with Dr. Edwards' need for personal protective equipment, including N95 masks and eye protection. Still predominantly sexual transmission, but remember, not an STD per se, but because of the close physical contact that occurs during sexual transmission. About 11.4% of cases are hospitalized, no ICU transmission, admissions, and just one death. Just to highlight, across most regions, probably with the exception of Eastern Mediterranean region, the mode of transmission is primarily among men who have sex with men, right? Whether we talk about Europe or region, the Americas, Southeast Asia, or the Western Pacific, it's predominantly among men who have sex with men. And in terms of age distribution, men between 18 to 45, 18 to 50 in this case, are predominantly affected. It's a 96% of cases are men, right? Just about 4% of cases are women. And predominantly, as you would expect, in a disease that is transmitted predominantly through sexual contact, you would see the involvement primarily of the age distribution of persons who are mostly sexually active, which would be young persons, and in this case of this outbreak, young men who have sex with men. And in terms, again, of the mode of transmission, primarily through sexual encounter, again, not a true STD, but through the close physical contact. Person to person, non-sexual, still over 2,000. And infection with contact with contaminated material, much less, but still there as a significant means of transmission. And the other much less common means of transmission. Again, this is WHO data. In terms of exposure setting, and this, I think, is particularly important. Remember, Dr. Edwards mentioned there was a rave in Belgium, and there were the transmission events because of that. Overwhelming amounts of transmission via in party settings with sexual contact, so raves, or sometimes you may have sex parties and so on. A large proportion of transmission is through this mechanism. So we have to be mindful about when we're thinking about prevention messages. Think about group sex activities. Think about activities where there may be large groups of people engaging in unprotected sexual contact. The next most common is through household, again, close personal contact, prolonged personal contact, use of same bedding, same towels, that sort of thing. There was some comment in the WHO brief regarding what a large event qualifies as, so there may be some issue with respect to that, but certainly we expect, if there are large events like parties or fests, especially there's a lot of crowding and close personal contact, and someone may have a lesion and you're bumping into people and so forth, that there may be a transmission event. So just very briefly, that Mpox risks are rising and continue to present a risk in our region. Remember, the largest number of cases is in the US. Cases continue to predominate among young MSM via sexual contact, and we need to think about surveillance of at-risk communities, because that surveillance is essential in identifying cases early and in limiting spread. That was just my very brief summary. So open for any questions anyone may have. So is that David Musa's there listening in?
Yes, Gregory, that's me. Good afternoon.
Hi, David. I wanted to ask a question. So during in 2022, I know the government did obtain procure some vaccinations. I don't know what the uptake was like. I presume it's safe to assume most of those vaccines have since expired. Would that be right?
I would need to confirm if they are still available and valid, given the fact that 2022 to 2024 is 2 years. The chances that they have expired are pretty high. Yeah.
Okay. All right. Ms. Marston was just off camera is just saying, I think the minister said the expiry is close, so we may have just a little time remaining for persons who may be interested in getting themselves vaccinated. Middle-aged and old people like maybe not to worry, we got smallpox, so we get one of the few advantages of being middle-aged these days. Any other questions? Anyone? Any comments?
I have a question. Hello?
Yes, hi, go ahead.
All right, so I would have been vaccinated against smallpox in my earlier years. I'm well over 50 now. I'm HIV positive. So persons whose immune systems are compromised, is it recommended that they be vaccinated if they could be vaccinated at this point in time?
So I think we have to be mindful about some of the vaccines are replicating vaccines. We have to be a bit careful about giving replicating vaccine in someone who's immunocompromised. They are non-replicating versions of that vaccine. In general, if it's safe, one would recommend vaccination with a non-replicating vaccine, but we have to be slightly careful with respect to how much protection it might afford, right? That the protection might not be as robust. But if there's no significant risk with respect to vaccination, I think probably the good public health message is protect yourself with a vaccine, but we may have to monitor protection levels.
Greg, there's a question in the chat from Rickson. He said, in the graph you showed on Mpox exposure, how do you define other? That is, what does other mean?
Outside those major categories, so not through not in a household, not in bisexual contact, not in a large group. So as with anything else, sometimes we will come down with cases, and for example, even with respect to HIV transmission, you would think in large categories such as sexual contact, sharing needles, XYZ. And there's always a small number of persons who go through the list and they claim they have been sexually active, they don't use injection drug use, etc., etc., etc. So I think anything that falls out of those large categories is sort of clumping to other. And it's more than one thing, I'm sure.
Hi, Greg. Just as a brief update, I've just checked with the principal pharmacist and she's confirmed that we have a supply of Mpox vaccine.
Anjali, your hand is up.
Pleasant good afternoon, everyone. I'm just wondering, I know this outbreak is only 2022, so it's a short period of time, but have we seen any kind of, how with COVID we had healthy persons developing certain complications? In terms of healthy persons and Mpox infections, have there been any trends or things that we're seeing happening as a result of the infection to otherwise, normal and healthy persons that don't have comorbidities or not immunocompromised?
As your presentation would have said, most of the persons who develop complications would have some sort of comorbidity. I mean, it's not impossible for persons without comorbidities to develop severe disease, but the rates are much lower. Right? Usually severe disease would occur more often when persons who are immunocompromised or have other comorbidities that would render them more susceptible to developing severe disease, as with most other viral illnesses.
Thank you.
So I suspect we will have to look out for the to see how things develop, because this is literally a week old, right? But I think we need to start thinking, because as previous experience did in fact show, whatever viruses travel across the world so rapidly. It can take a couple of weeks for someone to be exposed, maybe sometimes for business or on a vacation, and then come back and next thing they're back in the region and a lesion pops up. All right, so we will probably be guided by the Ministry of Health in terms of what they are going to advise us to do in terms of things like port screening and that sort of issue. I know the Minister will be speaking to that shortly. And Dr. Musa, we know we'll see you soon if that in fact happens. But I think it's very interesting, because I think they identified a new clade that seems to spread more easily among children. So that's something interesting to look at. So we have to keep an eye on that as well.
Well, that is very true, Gregory. And then the scientists all over the world keep warning us about new emerging viruses, and then you get the old viruses also developing new clades, which are more easily transmitted, apparently more lethal. And again, as you said, and truly so, there's so much of human movement in the world, and it takes a pretty short time for somebody to move from point A to point B, and in between, in transitioning or transiting through airports or ports, you get in contact with so many people, so no country is far from the other one. And if there are so many cases in a country like Brazil, which is not too far from us, then yes, all the healthcare providers need to be on the lookout for any suspicious symptoms that would suggest a possibility of Mpox, so that these guys are checked, diagnosed early, if any, isolated, and contacts traced, so that we don't have an outbreak that would be overwhelming to the country.
Well said. I can imagine, how well or how Port Health people sleep at night every time they hear something new pops up. How they I'm sure they work very hard to try to keep some of these things at bay as long as possible. And we remember, the tremendous impact COVID-19 had all over the world. We're not sure where the next pandemic is coming or where it's coming from, but we just know it has to come eventually, so we have to be prepared. I think if there are no other questions or comments, thank everyone for coming out on this Friday with Rickson.
Greg, hold on. I see a question just popped in. In a previous slide, it mentioned Mpox is presenting atypically. In what way is it atypical from Mpox in 2022?
Right, so Rickson, I think you may have missed the first part of the session. So that presentation actually was from Dr. Edwards in 2022, right? So he would have given a clinical updates about monkeypox in 2022. The presentation in 2022 was different to previous presentations in that there was more genital involvement. Usually with monkeypox, you would have gotten stuff from the skin all over the place, but not as much genital involvement, not as much proctitis. I think that's one of the things that they would have noticed, that people presented with rectal pain and tenesmus, which was not a common presentation prior to 2020. I haven't seen anything recent suggest that this outbreak is anyway different in terms of presentation than 2022 in 2024. But 2022 and to previous outbreaks, 2022 presentation was different. Okay, well, again, thanks everyone for coming out. We shall see you again in 4 weeks' time. This will be our in September, 4th week of September, for the financial year. So we'll see. I suspect it'll be Dr. Edwards giving STI on HIV updates. We still have to give an update about the IS conference. I mean, quite a lot of our nationals went, or 3 of us went from MRF, 2 nurses and Dr. Lyons. Yeah, so I think it was really well attended. So I'd love to get as many
I would love to hear.
updates as possible. All right. Good day, everyone. Take care. Have a lovely weekend. Cheers.
Thank you, Gregory. Bye-bye.